Okay, any questions by anything? Okay. So I have one more thing to finish up from last time. So if you remember that we were talking about health inequalities and why it is that sort of the explanation or how to view health inequalities, and kind of got into saying is that, well, in a lot of it deals with income, because basically payment levels are so much lower in area for Medi-Cal than for Medicare, and so much lower for Medicare than for private insurance, is that doctors, healthcare providers, and tend to congregate around places with higher income. Like my family lives all down in San Marcos and Escondido, down in Southern California. And about maybe 5 years ago, they started building this gigantic hospital on the hill there. I mean, it's beautiful. It's sitting on top. It's got 365-degree views. It looks like a castle up there. And now I just heard that Kaiser is now building one down there too. This gigantic new hospital, beautiful. So why are they all building beautiful? And I've been inside the other hospital, and it is really nice. Big atriums, nice rooms, everything. They have the food is one of their selling points is that they have the menu thing for the food where you just pick out the food that you want, like you're going into a restaurant, and it's pretty good. So why are they doing that type of high-end type of healthcare providership? Well, because they're trying to get private patients, right? And the same thing for Kaiser. Kaiser gets mostly private patients. Kaiser is moving into Medi-Cal now, but they get mostly private patients, and so that's who they're competing for. That's why community hospital closed down, because couldn't compete for the high-paying private providers. It's why Mariposa Hospital up there, John C. Fremont Hospital, it's probably going to close down, and it's not a place that because I live in Mariposa, it's not a place that if you get put this way, if I got something cut off, if I cut my finger off, I'd go to the hospital. If anything else happened, I'd either go down here to Mercy, but if I could live long enough, I'd go down to Fresno. And if I had cancer or something, if I had something that would require tertiary care, then I'd go to Davis or go off to San Francisco, because that's the what happens when you have a hospital in a region where there's lots of low income type of people, like there's in Mariposa. The guy who runs the hospital up in Mariposa, I was talking to him one time, and he said that he used to run the hospital over in Mammoth Hospital, flush with funds, beautiful hospital. And it's because Mammoth gets all the skiers who break their legs who all have insurance, not the people who cut their fingers off cutting wood like in Mariposa. So in the payment systems that exist explain a lot about where it is that doctors locate, where it is that hospitals are, et cetera. And so this idea of medically underserved areas, then, make sure you kind of understand what that's all about. Because these medical underserved areas, of which we live in one, it does explain a lot in terms of why it is that, like, you could get healthcare and yet not be able to get actually see a doctor. Like my wife just has a routine checkup that she needs, so she called up the doctor in Mariposa, and they said, "Oh, we're not taking new patients, but maybe in 6 weeks, then we'll start putting you on the waiting list to take a new patient." So you just can't get primary care in places like that, so there just aren't enough doctors. Okay. Then last thing I want to sort of explain about, giving you my perspective in the healthcare system is in terms of racism, is that, what role does racism play within the US healthcare system? So, I can give it to you, I can put it online, but it's a big report from the CDC. And the CDC has put out these reports that basically show, health inequalities or health inequities across a vast number of different type of conditions. both, health conditions, but also access to care and everything else. It's pretty, it's an uncontroversial fact is that these type of health inequalities exist. So I'll give you my little, so I'll just focus on healthcare right now and upon how the healthcare system has kind of, how should I say, how it's dealt with racism throughout throughout time. So from my reading, if you want to think about before the 1960s, the healthcare system in general was something for which, that focused on individuals and behavior, as that there was the idea that for the most part, it was governed by a biomedical model, which we'll talk about in a little bit, which meant that it viewed the body as sort of, people did these things and that led to ill health, and that the role of the healthcare providers was to come in there and try and make people better. But the idea is that health sort of happened kind of outside of it. So there's a lot of what you might call blaming the victim that occurred for all races, just the way the healthcare system viewed people, viewed what they did, is that people would do these things and get sick, and then that they were there for, they would try and treat them as best they possible, but with the understandings that they might go back out and do, things again that get them sick. And so as a result, there wasn't really, I don't, from my reading, like a lot of discussion about the role of racism. You get things that happen like the Tuskegee experiment, which, clearly is like, racist to its foundations within public health. And yet there wasn't really that much sense that this was, wasn't really kind of an issue. So I think that, the conclusion from like pre-1960s is that, it was a major issue, obviously, but yet healthcare as an institution didn't really deal with it. Like I'm positive that doctors in the 1950s weren't trained anything on things like this. Right, 1960s to 80s, I think within healthcare, you can sort of view this as like the idea of focusing upon racism at the individual level. So, because of a lot of the events of the 1960s, is that, the kind of the white communities within the U.S. started to sort of say, well, yes, there are people who are racist. And within healthcare, there was this idea is that, yes, there are healthcare providers who are racist. But the idea was that these were sort of bad apples. And so therefore, the assumption being is that if you could go through and you could just kind of get rid of all the bad apples, and that was the goal. And so a lot of the training that went along within healthcare was about kind of, talking about racism, but the idea being is that, most of people are not going to be racist, and it's only going to be these, individuals that you could recognize and that, wear Nazi flags and things like that who are going to be the racist ones. So there wasn't what you would sort of, kind of call any type of more nuanced view of racism. It was basically just, we'll try and identify people who are racist and get rid of them. 1990s to 2000s, that's where the idea of implicit racism kind of came in. And it came in for all things like academics too. So, when we used to hire people, well, this was before my time, but when people used to get hired in academics, is that, they just bring them in, interview them, and then hire who they want. And not surprisingly, older white men would hire younger white men in these positions. So in the 1990s, within academics, the way that hiring got done then was started to explicitly acknowledge the idea of implicit racism. That is that it's not that people think of themselves as racist. It's not that they, in their actions view anything that they do as racist, but the outcomes are still the same. And so a lot of the training then became kind of looking at implicit bias within people's decision-making. And the same thing for medicine as well. And so a lot of the training during this period for healthcare professionals was about what implicit bias is, the role implicit bias can play, and then the things that you could do to kind of overcome implicit bias. And if you start looking at like, some of the ways that it would come out, one way is access to specialist care. So there's some studies that started to come out where people would look at why is there such a big difference between outcomes for African Americans and whites for heart disease? Because it was, startling, really, really startling kind of differences in terms of life expectancy. And what they did is they started looking at, well, who gets access to care? And they found that there wasn't that much difference in terms of access to primary care. But what there was a big difference is access to specialist care. So like if you have heart disease, you go to your GP says, ooh, you really need to see a specialist for this, right? So what happens is that, well, most people call up and try to get a specialist, and you're on a waiting list for, however long you're on there. What doctors will do is that doctors will advocate for patients, right? So doctors, like a doctor might call up the specialist and say, hey, I've got this patient who's really, really, really sick. And so therefore, needs someone to see him right now. And the specialist is more likely to see that person. And what they found was that, white doctors were more likely to advocate for white patients than they were for African-American patients. They also found that, African-American doctors were more likely to advocate for African-American patients, but because most, healthcare professionals were white, is that this was leading to a lot of the types of problems. It was just the access. And so it wasn't something where, you wouldn't look at that and sort of say, oh, well, that's explicitly racist, but the outcome was still the same. Another one is removal of diabetic feet. And this was a big one here in the region. So if you look at the rates by which, when someone gets diabetes, one of the big complications that can come is that they start to, need to get their toes amputated and their feet amputated because their circulation gets bad. And so if you've got a good kind of treatment of diabetes going, is that you can avoid that. On the other hand, if you don't have good treatment of diabetes, then it can easily go into kind of moving into this diabetic foot, which can lead to amputation. And what they found is that, well, rates of amputation were much, much higher among Latinos in the valley than whites in the valley. And the question was why, right? Why would the rates be so much different? And it turned out because that doctors, what they were doing is they just weren't giving, if a patient came in, a low-income patient comes in, or a patient doesn't speak English, they'd be much more likely to say to them, well, you really just need to amputate your foot, and not sort of give them the treatments and kind of go through the process of seeing if they could basically get them to just monitor or control their diabetes. And the rationale was, because I see patients come in, they're in this stage, I try and get them to change their lifestyle or whatever it's going to be, and they don't do it. So therefore, it's just easier for the patient just to go ahead and amputate it right away. So, racist, well, it's implicit, the doctors didn't think of themselves as being this way, but implicitly, that's what the actions were still the same. Then I think what's happened since 2000 is that there's been more of a kind of a focus on a recognition of structural level racism that exists within healthcare. And so where this differs is that it kind of means that, well, you can have healthcare providers who, aren't overtly racist, and you can have healthcare providers who aren't even implicitly racist, and yet you can still come out with outcomes that are different. And so the focus here is upon things like, well, like being in medically underserved areas, things for which, that it's not, if you look and ask any particular provider, do they want to have worse health outcomes for people in medically underserved areas than not medically underserved areas? They'd say, no, of course not. At the same time, there are fewer doctors and there's worse doctors and everything else that goes along with still having worse outcomes. And so what's been happening in healthcare then is this switch over to, like especially within public health, is to trying to recognize and trying to deal with problems at more the systemic racism type of kind of focus, which means looking at really more the conditions, not necessarily just the attitudes and behaviors. So, I think that's kind of where I'd say things sort of sit right now. So when we start talking about differences about the healthcare system and start talking about all the different types of problems within the healthcare system, just keep in mind is that, one is the idea of health equality. And the idea is also that, these things are not just sort of randomly distributed, right? Poor health outcomes and poor health infrastructures are not just kind of strewn across the landscape and affecting everyone equally. Okay. So to conclude, this is the conclusion of the US healthcare system overview, is that every healthcare system has problems. Canada, waiting times are the big problems. Germany, regulating insurers is the big problem. In New Zealand or Australia, running the hospitals is a problem. In India and Colombia, trying to get people access to healthcare, healthcare is a problem. So every country has problems. What makes the US special is that we have all four problems at once. And what makes it even worse is that people go between different types of programs. And this is really what causes a lot of complications. So if you are someone who gets a job, and so you're suddenly making above 138% of the federal poverty line, so you no longer qualify for Medi-Cal, now you have to go out there and try and find health insurance through Covered California or whatever it's going to be. It's going to be more expensive. And then you get laid off. Now you suddenly go back on Medi-Cal. And so now you have to apply for Medi-Cal and wait for it to kind of come in. If you move areas, you have to reapply for Medi-Cal. If you change addresses and that even if you don't reapply for, if you're still in the same county, you might get kicked off because Medi-Cal doesn't have your new address. So there's all these different problems that can occur along the way. And also just it becomes really, really problematic. If you've ever had to go into healthcare to deal with a hospital, is that it's usually a time when it's very stressful because someone's sick and very, not very well off. And suddenly you're having to deal with all these issues about what the insurance is going to pay for. Where are they going to go for long-term care? Who are you going to be able to get home help? All these different type of issues that come along. And the system is not very good in terms of helping you navigate through those things. So we'll talk about ways that, some of these things can be made better. We'll talk about programs that can kind of help this, but just realize that for most people, this is their experience with the healthcare system, is that they like it when they don't have to use it. The more you like it, the less you tend to rate it as highly. Okay. Questions about that? Any questions about the US healthcare system? Yeah. Why did we decide to have the four systems together? Why do we have those systems? Oh, we'll talk about it. I mean, that's why I'll talk for several weeks about the history, because, it's not a system whereby, it's not like someone said, I know, let's have a system where we have all these different type of systems together. But it's just because of the historically, the way that healthcare has arisen here is that's why we have these type of systems. And we'll talk probably more than you want to hear about it. But the reason I'm going to do it is because, to really understand the healthcare system is that you kind of have to understand why it is that we got this way. I was just talking to I'm doing this project for the California Department of Public Health. We're trying to look at, they're trying to look at how to support local public health departments. And so I was just on this conversation with a woman from who's the public health medical director up in a couple of counties up north. And she was saying is that she's trying to do these things she's trying to work with the FQHC and trying to work with the hospital. And so I said, well, do you think that one of your roles might be to just try to be the overall coordinator of things? And she, shook her head and said, no way, the healthcare system is just too complicated, too fragmented. It's like, she's lived overseas, so she understands kind of what it's like in the system that all kind of operates as one, and says that in the US just can't do it. And this is not just like between hospitals and the FQHC, but it's also between like what happens in the Medi-Cal purchaser in the state versus what happens at the federal level versus what happens at local levels. It's just a mess. It's a mess. That's what it comes down to. Okay. Any other depressing comments I can give before we move on? All right, so what I want to do now is I want to sort of change gears, and that what we'll do is I'll go through probably starting Monday or Tuesday. I'll go through and start talking about, how we got to where we are, but I'm going to break it up and also kind of come through and talk about what we might think of as big topics that you need to know to understand the healthcare. So the first topic we want to go through is wants versus needs. Okay. So to start, let's just start with what is health. Right? So what do we mean when we talk about health? Because we're going to be talking a lot about how we measure health and comparing the health between different countries, et cetera. So here is, let's see if I can get this. So there are various types of websites. This is just one that kind of summarizes different type of information. So this is for the US. So what this shows is this is the population pyramid. So what it shows is basically the percentage of the population at each of these different at different ages, right? So you have the ages going up this way, and you have the percentage of population for both males and females going this way. So like if you look at 1950, you had a lot of people 0 to 4 years old. And then you have fewer people in this range, especially fewer males. Why is that? Why did you have 1950 a lot of, World War. Yeah, World War II, right? World War II killed off a lot of young men, right? So you have this blip. At the same time, the men who came back, what they wanted to do is have children. So 1950s, this is the start of the baby boom coming through here. All these young kids coming through. 1960, still in the baby boom, right? Lots of young kids. 1970, now you're starting to see baby boom ending. So this is the blip here that's moving through. 1980, 1990s, 2000s. So in the 2000s now, the baby boomers are the 50 to, and moving through 2010, and then now here 2020. So there's your baby boomers right up here now, right? So notice is that, it's a big blip. And the reason that when we talk about Social Security and Medicare, the reason why there's so much dire predictions about Medicare and Social Security is that two things are happening. One is that you get this group here is, larger than the group of working people down here, which means that when I retire, all of you will be working to support me. So thank you. Keep working, keep those jobs going so I don't have to lose my Medicare when I retire. And the other thing you should do then for your own sake, what should you do for your own sake? If you want to, make sure that when you retire, you have good Medicare. What's that? Have a bunch of kids. That's what you should do, is have a bunch of kids. So you should have lots of kids, and that, and also, bring in a bunch of people who are going to have kids. So immigrants who are going to have kids. So young immigrants. And then the idea being is that you want to get lots of young kids so that they support you in the old age. Let's take a look at Japan. Japan's a good example of a country that's, let's see, there it goes. Here's Japan. Okay, so Japan, 1950, right? You notice that they really have an inverted type of, because Japan lost so many people during the war that, so, they look like that. And in 1960s, 1970s, 80s, 90, 2000, 2010, you can see what's happening here is Japan has lots of old people and not very much young people. 2020. And the other thing that happens is that Japan has the longest life expectancy. So, this means that you're kind of going up at this stage. You're getting more people who are in this age here. 2030, 2040, 2050. So that's a situation there where Japan's in trouble, because it means that by 2050, they'll have very few people who are working age and they'll have this whole mass of people who are of older age. So, at retirement. So that's why in Japan, one of the big, Japanese know this. And so one of the big things that Japanese have been doing for years is saving, right? Putting money away because, the older generation, because they know that they don't have trust that you're going to have a social security system when they're in their old age. Okay. The other thing is that this, I mean, it stops at 95, but you're not necessarily getting a huge number of people living to be 100 still. It's kind of, I mean, if you think about all the medical advances, is that the medical advances, they've increased life expectancy, but they really haven't increased the life expectancy of the top, of what's at the top of the range. People still, people used to die, like in the 1960s, the life expectancy in the States was, what do you think the life expectancy was in the US in the 1970s? No, not that bad. No, a little bit lower, about 65, right? It was about 65 in the States. What's it now? What's our life expectancy? Yeah, 70, 78. I think it's down a little bit for males. I think it's like 77 for males, but it's around there. So it's gone up, right? But at the same time, what you're not seeing is you're not seeing life expectancies of 120. So even though all the advances of medicine, it's not like the top life expectancy has really gone up that much. People tend to not die in their 60s as much. People, tend to you have many more people in your 80s, 70s, and 80s. But, being in the 90s is still relatively rare, and being over 90 is still really, really rare. Okay, let's go back to the US. Go. Then what this shows is the life expectancy by age. So essentially it means like if you are at birth, the life expectancy for males is 76 and it's from females 87. If you can reach age 25, then you're at 77 and 81, right? And if you reach age 65, then it's 83 and 85. So, it gets higher the longer you live. You obviously haven't died yet. And so therefore you have more of a chance to keep living at that point. So this shows the life expectancy if you're at a given age like that. What this shows is that this shows kind of different types of health conditions. So coronary heart disease, Alzheimer's, et cetera. And then this shows the world ranking, where the red is bad and the purple is good. So let's see, diabetes, we're bad in diabetes. Why are we bad in diabetes?
That's a lot of sugars.
Yeah, because we're obese, right? Because we have high obesity rates compared to other countries. We'll look at Japan after this. So we're bad in diabetes. Let's see, we're bad in drug use. The fentanyl crisis has, and the opioid crisis has made it so that we have the highest death rates in the world. Hepatitis C, we're bad. So some of these things, are bad, like multiple. Some of these things are bad because just because of things like the drug crisis, right? Other things are bad because of like hepatitis C. They have treatments for hepatitis C. So this is kind of a sign that the healthcare system isn't doing very well if you have that. On the other hand, let's look at Japan. See what Japan looks like. There it is. So there's Japan. So Japan, pancreatic cancer is bad. Why would pancreatic cancer be bad? Well, probably because that's something for which, you tend to die when you're old, is pancreatic cancer. But for the most thing, they have pretty good outcomes in most things in Japan. And they also have a life expectancy of, 87 and 81. Let's pick another. What country should we pick? Which one you want to see? How about Colombia? Let's look at Colombia. So there's 1950s, lots of, so, countries, countries, what happens is that, if low income country, is that you can have most of your deaths from infectious diseases. And then what happens that as you get more wealthy is that then you have more of your deaths by chronic diseases as you get older. So that's called what's that called when you go from a country has most of their deaths from infectious diseases to having most of their deaths from chronic diseases. You should learn this in your intro classes. It's called the epidemiological transition, whereby the country switches over. So in the U.S., we switched over about early 1900s. We went from most deaths being infectious diseases, like, pick a country like, I don't know, Sudan. Let's look at Sudan. Yeah. So Sudan, very high birth rates, and then they're still kind of in that here, 2010. They're still, they don't look that much different than 1950s Sudan in terms of what it's like, Sudan, war-torn country, et cetera. But they're still in that phase where most deaths are from things that aren't the same deaths that we have here. Like, so, heart disease, low birth rate, measles, leukemia. So these things are all things that could potentially be treated. All right, so these are all different types of health conditions. And then they have cancer rates. They used to have a whole big thing on, they would show here it is. Then it shows the COVID. So back when, 2020, 2021, this sort of led everyone's website was what was happening with COVID. But so that's where the COVID looks like in terms of the number of deaths across time. So it's showing you across the time how many people are dying. So if you let's look at Italy. Here's Italy. So Italy got hit very early with COVID. So, this is the death rates from COVID then and how they increased over time in Italy. So it looked like that, right? So the reason I'm showing you this is that, so this is the type of things that if you want, when you think about health statistics, is that there's lots of places to get health statistics. And each of these things are sort of different types of measures of health. Okay, so there are, some of the major ones that you're going to see is one is mortality. So mortality is life expectancy. The second one is morbidity, and morbidity means, so mortality means death, obviously, but morbidity kind of means ill health. And there's lots of different types of measures of ill health. So most of those things that we looked at in terms of the causes of death, those are actually morbidity type of measures. And so oftentimes when we start talking about countries in general, we'll talk about the rates of these various things. Then there's summary measures. So summary measures is where you kind of combine it together, to something. So for example, disability adjusted life years, DALYs. You'll see this thing a lot that's mentioned. Quality adjusted life years, QALYs, but other types of things too are kind of composite measures of health. And then cost, you'll see cost reported a lot as a measure of health because people care about the cost. All right, so we have generally 3 different types of measures there. So you can have direct measures of health. Those are things that we report because we care about them. You have prevention. So those are things that we report, not necessarily because they're linked to health itself, but because it signifies that in the future, you're going to reduce some type of health problems. And then the third one is proxy measures. And proxy measures are measures of health where they tell you something about the healthcare system. So why don't you take 3 minutes and tell me which of these things are direct, which of these things are prevention, and which are proxies. Okay, so get together and just talk among yourselves. And come up, I'll give you 5 minutes. Yep. Yep. So a direct measure of health is something that you care about just because you care about it, right? So that's something that's important to us. Like, what's life expectancy? I'll give one to you. Life expectancy is a direct measure of health. People care about, how long they live. So that's a direct measure of health. Prevention is something for which, maybe you don't care about per se, except for it's associated with health in the future. And then proxy measures, those are things for which you don't really, they're really signals of something else that you're reporting them, but they actually signify something different. Okay. All right. So there you go. Direct, prevention, or proxy. I'll give you 3 minutes. Go. And if you're sitting alone, then just rank them, because I'll call on you and you can then tell me what you think. Yeah. Okay, ready? Are we set? Okay, I'll randomly point to someone. I'll point to you. You took a good picture of yourself. So we'll take the infant mortality. Is that a direct, a prevention, or a proxy? So which one do you think? I'll give you a hint. They're both it. It's both, infant mortality is both a direct and a proxy. So well done. It's a direct measure because we all care about children, right? So therefore, infant mortality is one of those things that for which we just, you don't want to think of children dying young. But it's also a proxy measure because infant mortality, especially in a country like the US, is preventable. And so if you have a high infant mortality rate, that means that something's wrong with your healthcare system. Do we have a high infant mortality rate in the US or a low infant mortality rate? What do you think? High, medium, or low? Low. We're very, very poor. Very, very poor in the US. Shockingly poor in the US. Why don't we have, what's the number one thing that leads to lower infant mortality that improves outcomes? What do you think? What's that? No, well, you're on the right track. Prenatal care, right? Prenatal care is like the number one thing. So the earlier you can get women into prenatal care, and that, then the better the outcomes. So therefore, the US is bad because our healthcare system is not very good at getting people into prenatal care. So well done on that one. Lost year's life. What do you think? Direct, prevention, or proxy? Direct, that's right. We care about lost year's life. Quality of life, direct, prevention, or proxy? Now, quality of life is an index, right? So there's different ways to measure quality. It's like there's not something called the quality of life. You have to have some type of quality of life measure. So there are different types of ways of measuring quality of life. So what do you think? What do you think? Direct, prevention, or proxy? Why do you think that? Mm-hmm. What if you said, what if depression? Would depression be a direct, a prevention, or a proxy? I think direct, right? You know, I mean, you can see is that these are not like, it's not like Moses came down from the mountain with a list of what's a direct prevention and proxy, is that this is all sort of a matter of debate, because what it gets to is sort of what it is that we value. And so I think that in society, there's an increasing recognition that depression is something which is something that we care about, not just because it's, not just because of some future thing or whatever, but just depression is a bad state to be in. So I would say direct measure. Vaccination rates, prevention, direct, proxy. Yeah. Ding, ding, ding. Well done. Yep. Prevention and proxy. That's what, at least that's would be my answer too. Because I think it's prevention because, on one hand, vaccination rates themselves, it's not something for which you sit there and think, oh, that's really gonna, we've now solved our crisis by vaccination rates. But what it does do is that it leads to better health in the future. But then it's also a proxy because if you have high vaccination rates in the country, it typically means you have a pretty good health system. And if you have low vaccination rates, then it means that you have a pretty poor health system. So, one of the first big vaccination campaigns was polio vaccines back in the 1950s. Did the US do a good job with polio? Did they do a fair job with polio, or did they do a bad job with polio? They did a good job with polio, right? When they would come to schools, they really wouldn't eat. I got vaccinated in school back in the 1960s. I think that's when it was that they started. They're coming to the schools, and they really didn't ask. I mean, they sent home something to the parents saying, "Good news, your child's going to be vaccinated." But there wasn't like a lot of protest. In fact, there's none. There was no protests against it. So vaccination rates back then were very high. How do we do on COVID vaccinations? Would you say we did a good job, a fair job, or a poor job? Yeah, so COVID vaccinations more problematic. But then you can ask yourself, well, was it a public health problem, or was it a societal problem, or what caused it? So it's unclear, or I should say it's debatable, what it is that poor vaccination rates for COVID is a proxy of. Poor infant mortality outcomes, clearly a proxy for bad healthcare system, right? But some of these other things start to get into different type of, like obesity rates. Is obesity a direct, a prevention, or a proxy? How about in the back there? Very back there. Obesity, direct, prevention, or proxy? Uh-huh. So why both of those? Uh-huh. Yeah. Why not? Well, so I would argue it's probably not a direct one. Yeah. Because obesity by itself is not, I mean, unless you're really, really obese, obesity itself is not really a health condition. I mean, it's not associated with bad health. What's associated is that if you get diabetes from it, or heart disease, or things like that. So it's kind of a proxy. I mean, more of a prevention type thing, because you're really talking about future type of health. It's associated with a number of different conditions, but in itself, it's not necessarily a health condition. And then I think proxy, because it sort of says that, well, Well, I don't know. What's it a proxy of? Yeah.
It represents whether nutrition has a sort of like American value perspective.
Right. So it'd sort of represent that probably something about society is not good. Is it the healthcare system? Well, we'll talk about that. See, is obesity now? Because I think like is obesity something that the healthcare system can do something about? Like, what can the healthcare system do about obesity? Yeah.
About the obesity as all because sometimes some people don't know that
Mm-hmm.
so, or what obesity is like they really are not informed, especially places where they're not even for systems. So I feel like that's the most I feel like our healthcare system. There's so much they could say and they could give information about, but it's ultimately up to us. When it comes to our diet or what we eat and if we even want to do it.
So they can provide information. Yeah. They can provide liposurgery, or liposuction, right? That's a medical procedure. Can they do anything else? Oh, yes, they can. What else can they do? They can give you. Yeah, what's the name of the drug that they're all taking? That's sweeping Hollywood. What's the name of it? What's it called? Sounds good to me. It's the one that basically that they're all taking. It's a diabetes drug, right? It's a diabetes drug that's been shown that if you take it, it suppresses your appetite. I think it also causes massive gas and things like that. But yeah, but you lose weight. So there you go. So, but now, so you'll see what's going to happen is that now obesity will start to become talked about a lot more like a medical condition, whereas before it was a medical condition, but not really one that that healthcare providers could do much about. I mean, they could tell people about, but for the most part, the causes of obesity is not bad healthcare. The cause of obesity is lots of other things that goes along with it. But now they have a drug, and the drug that there was the drug. What was it called? It was the synthetic stuff they used to put in foods like in potato chips. Basically, it caused massive violent diarrhea. So that was an unfortunate side effect, it turned out. And so that kind of went away. Lestra, is that what it's called? It was like this fat substitute that was supposed to make it so that, that you weren't going to absorb food. So therefore you could just eat all you want and it would just, but it turned out it passed through a little too fast. And so that one kind of went away. But this one seems like it's there. Yeah. Lestra. Yeah. Okay. Cost of healthcare. Let's see. Direct, prevention, or proxy. What do you think? Direct. Someone back there in the back of the room. Direct prevention. Yeah. Why is that? Yeah. Now I would agree with you. So I agree. Direct and proxy. Say direct because we care about money, right? And proxy because if you have a really, really expensive healthcare system, is that it's kind of the sign of inefficiency. And so the reasons why they compare between different healthcare systems, how much they spend, is because like the US is twice as much as most of the world, right? And yet you don't necessarily see better health outcomes in the US. So the idea is that we must have a really inefficient system if we're spending twice as much and we're not getting any better outcomes. So that's kind of a cost is being used in that sense as sort of an efficiency level. All right. Next, so that's one thing. That's the first kind of thing to kind of keep in mind is how we measure health. Second thing is the sort of the way that health is viewed. So show me with your thumbs, how many in your classes have talked about the biomedical and the psychosocial models of health? Where you say, yes, I've talked about those a lot, versus no, I've never talked about those things. Show me with your thumbs. Okay. So I'll give you a quick kind of overview about the two models. So the biomedical view of health is what has traditionally been kind of what's governed healthcare providers. And truth be told, probably still does, but now they'll all profess to the psychosocial model of health, but really, a lot of them still kind of operate under a biomedical. A biomedical way of viewing health is that, well, health means the absence of disease. So if you are a healthy person is someone who doesn't have disease. Someone who's not healthy is someone who has a disease. And so the idea is that, you've got this, if you get sick, you get this level of need. And then you come into the healthcare system, and the healthcare system then tries to restore you back up to where you were. So optimum health by this means an absence of symptoms, or at least an absence of symptoms that they can do something about. And they're kind of rolled and ends after they've done what they can for you. So it's a very reactive type of system whereby, people get sick for various reasons. They come into the healthcare system. Healthcare system does things for them. And the healthcare system, once they're done doing things for them, then the person is released back. And that if the healthcare system could bring them back up to optimal health, great. If the healthcare system only brought them partway, well, that's just the way it goes. And if the person died, well, that's the way it goes. But the healthcare system would do what they could for the person. The healthcare industry then, so you can think about that as in terms of the whole collection of healthcare providers. So hospitals and everything else kind of goes into this idea of a healthcare industry. And so the idea is that the way a healthcare industry would work then is that people would get sick, they would come in, and then the healthcare industry would react, right? Would give them things based upon their level of need. So if you had a little bit of need, then you get a little bit of healthcare. And if you had a lot of need, then you get a lot of healthcare. So the way to think about it is it's like a thermostat in a room, right? So if it's a little cold outside or a little hot over the heat, it's a little hot outside that you have the air conditioner works a little bit, but if it's really hot outside, the air conditioner, you turn it on full blast, because what you're trying to do is you're giving as much sort of healthcare in this case, depending upon the level of need. So if someone's a little sick, they get a little healthcare, but if they're a lot of sick, then they get a lot of healthcare. When do people tend to be the sickest? And if you look at their lifespan, when do they tend to be the sickest? Yeah. Yeah, that's right. At the beginning, and then when they die, tends to be the point where you need healthcare the most, right? And so, if you focus on when newborn babies come along, we're kind of all in with do what we can, everything that we can for them, because they have a life in front of them. We all love babies, so. But what was happening for older people is that older people would come in and they'd be near death, and the healthcare system would try and do what was called heroic medicine. Heroic medicine means that, you've got this person who's dying, so you're trying to stop them from dying. And so you're going to give them as much health care as you can to try and stop them from dying. Now, if you do that, then what's going to happen is that you're going to be spending a lot of healthcare on people who are eventually going to die. So it becomes kind of tricky because on one hand, if somebody comes in with something that, like if a 30-year-old comes in with sepsis, let's say, right, with something that's, they're going to need massive amounts of antibiotics. Well, I think that most of society would say, yes, let's do that. Let's give this person massive amounts of antibiotics to kind of keep them alive, because they've got, a long life in front of them. It's a condition that if you can treat it, they get better. So we're all in on that. On the other hand, if somebody comes in and they've, got terminal lung cancer, and they've got, dementia, and they just had a stroke, and they have sepsis too, is that then, are you going to do it in that case? So would you do it in that case? If somebody came in, because, it's an infection, right? It's just an infection. So it can be treated with massive amounts of antibiotics. But would you, if somebody's in that stage, would you come through and treat them with massive amounts of antibiotics? And your answer could be yes, could be no, but you can see is that you're kind of in this world where you're trying to figure out, well, how long the person's going to live, and will the antibiotics really work? I mean, if the person has all these other types of things, And so, what was happening is that they were spending enormous amounts of resources at end of life and doing things like just doing things to extend life by a couple weeks, a week, because that's what the healthcare system did, is that they tried to save people, and that they, doctors weren't trained to let people die. That's a biomedical model. The psychosocial model, it goes, by different types of names, determinants of health model, public health model. It's probably what, everything that you were taught in the public health classes kind of goes under that type of heading of psychosocial model. But rather than, remember, under the biomedical, health just means absence of disease. So if you don't have disease or a condition, then you're healthy. If you've got some type of disease or condition, then you're not healthy. Well, under the psychosocial model, it means kind of complete physical, mental, social well-being, and not merely the absence of disease or infirmity. And that the key is that it's sort of this individual determinants level. So under the biomedical model, health was kind of determined by these things that are kind of outside. You do things, you get sick, and then, the healthcare system reacts to them. Under this model, it's like, well, all of that thing is part of the everything that gets you sick out there is part of should be considered as part of of what the healthcare system does. So the healthcare system in this case then is not just sort of treating people when they come in the door, but it's supposed to be treating the underlying determinants of health. Okay. So, and we'll hang on to that thought, because when we talk about, probably do it on Tuesday of next week, when we start talking about public health interventions, then public health interventions are going to differ from biomedical interventions, because public health interventions are going to focus on underlying determinants of health, and biomedical interventions just focus upon the condition. So keep that in mind. Okay, next thing, wants versus needs. So biomedical model, based on the idea that someone is sick, has a need, and that the healthcare system responds to that need. So there's in terms of what's the difference between a want versus need, it's kind of tough. I would say a want is something that you would like to have, but it's not essential. And a need is something that is required. Would you agree with that? Is that the difference between a want versus a need? Like, do I need this LaCroix tangerine, or would a cup of water be okay? Suppose I had a cup of water or my LaCroix tangerine drink. Do I need this drink rather than a cup of water? How many say, yes, you need that tangerine LaCroix, versus how many say, no, you don't, you have water? So why, you're such hard people, why is it that you think that I don't need this tangerine LaCroix? I like it. I like that. I prefer my tangerine LaCroix to my just tepid tap water. So why is it that you see that as a want and not a need? Yeah. Uh-huh. Okay. How about if it was water versus nothing? Would I need the water? Okay, so why do I need the water? So there's some type of consequence that would occur where, like, if I didn't have the water, that I might, suffer bad health outcomes. So we all need water, but we don't all need LaCroix. You all agree with that? So let's go through and sort of see, in this case, in each of these cases, does the person need healthcare? So 45-year-old man walking outside here gets hit by a bus, breaks his hip. Does he need healthcare? Show me that yes, he needs healthcare, versus no, versus somewhere in between. So yes, okay. So why does he need healthcare? Yeah.
relatively mobile. And so you would need like the hip to like walk and stuff.
Excellent. How about the 85-year-old?
85, that is like.
Let her die. Let her lay out there in the gutter until the crows eat her while she lays there. So 85. Would you say that 85 is
I feel like 85-year-old can walk.
okay? So you're gonna let the 85-year-old get the hip, okay? How about 85-year-old with terminal cancer? Would that matter? Or do you want to just say everyone who breaks a hip should get? How many say everyone who breaks a hip should get a hip replacement, regardless of, even if you're on your deathbed, you still get a hip replacement? Yeah? No, not if you're on your deathbed? No? If you're 3 weeks away, well, how long does it take if you get a hip replacement, how long does it take to recover? In about 6 months. In fact, the life expectancy for maybe it's changed, but a few years ago when I did a study on this, the life expectancy of people who break their hips after the age of 70, I think it's 6 months. It's not very long. And it's because what can happen is that maybe it's 80. It was 80. After 80, it's 6 months. Because what happens is that, breaking hips really bad, right? And you have to lay in bed. And so you get immobile and you lose the ability to kind of get out of the chair. And then you get bed sores. And so it's really, it's not a good thing to break your hip when you're really old. It's gotten better. They're better at doing it now. But, traditionally, breaking hips has been a bad thing. So that's why terminal cancer at 85, maybe you don't replace her hip just because she's going to be miserable from having the hip replaced. And so it's kind of like, in that case, are you doing her a favor by going through and breaking it? Because, you could just give her pain medication and just say, well, we're, broke your hip, we're going to give you pain medication. So you're going to spend the rest of your life, you're going to experience the joys of opium for the rest of your life. Do they do that type of thing? Just give people opium toward the end of life? Yeah, that's called hospice care, right? So hospice care is essentially what's arisen as a way of kind of dealing with that end of life situation. So, and hospice doesn't mean that you're on death's bed, but it means that no longer can the medical care system is not going to make you better. And that the end is, if not near, you can see it coming. And so hospice care, it's a different philosophy because they're not there to do heroic medicine. It's there just to help you sort of transition out of this world and into the next one. Okay, so how about 6-month-old baby not vaccinated for MMR? Is there a health need? MMRs, measles, mumps, and rubella, right? Bad for babies to get those things. Bad for adults to get those things if you're not vaccinated. So does the baby have a health need? How many say yes, the baby has a health need versus no, the baby doesn't have a health need? Okay, so keep that thumb up. Now show me, what if the parents don't want it? So if the parents don't want to be, is it still a health need, or is in that case then, no, the parents don't want it, then no health need? So you still say yes. Override the parents' concerns.
Like legally, like the doctor, but that doesn't change the fact that the baby still needs the doctor.
Uh-huh. And why do you think that?
Because like they're like
Yeah.
And not measles, not like that really affect the child.
Uh-huh. How about breastfeeding? Should women, because breastfeeding is good for babies, right? Should women be told you have to breastfeed your baby? It's better for babies.
It is better for babies,
Yeah.
but there are like alternatives that maybe aren't as good, but are still good.
Yeah. So how are you making this decision about? So you're comparing what's the probability the baby's good? If the baby doesn't get MMR, what's the probability they're going to get measles, mumps, or rubella in their lifetime? Very low. Very, very low chance that you're actually going to get it, right? Because they talk about herd immunity. As long as the immunity levels are above, 90%? I mean, part of the reason why it's been an issue previously, in recent years, is because so many parents, mostly, kind of middle class or, white middle class parents have not wanted to get their kids to get vaccinated. And so now you're falling below that herd immunity level. So remember a couple of years ago, there was a big outbreak in Disneyland of measles. And of course, it's kids who aren't vaccinated and parents who aren't vaccinated, but it's also newborns. I mean, that's the ones you really care about. So that's why they really focus on getting that vaccination level above a certain point. But from a parent standpoint, right, it's like, yeah, as long as everyone else gets vaccinated, then why is it that, that my child's not going to be getting measles, mumps, and rubella? So therefore, not an issue. But breastfeeding is something that probably would help. So how many think we should force women to breastfeed their baby? Force, okay, we won't use the word force. How much do you think we should pay them $100 a week if they breastfeed their baby? So me, yes or no? No? From a societal standpoint? But you want to encourage them. You want to encourage women to breastfeed babies. So why don't you want to say, why don't you want to get more, from a society standpoint, if it's good for the babies? What if the parent wants to give a tattoo on the baby's head? Should we allow that? Okay, no on that. So you're not going to allow, so you're going to restrict the parents' rights for some things, right? And you want to go ahead and override the parents' rights for MMR by saying that the child should get vaccinated. For breastfeeding, though, woman's choice. Is that right? Okay. 45-year-old man does not get vaccinated for COVID. Have a need? $85-year-old man with multiple health conditions not vaccinated for COVID. Have a need? I mean, if he gets COVID, multiple health conditions, probably die, right? So does he have a health need? I mean, because the question is not does he benefit from it, but from society's standpoint, do we say that this person has a need or not? Time. So think about these ones, and we'll start there next time. In fact, next time I'll show you where we're going to go. We're going to go to this one. Will you pay for my facelift? That's the big question. All right. Have a good weekend.